Hey, welcome back to the Lifestyle Medicine Network, where we focus on the science of lifestyle modifications and the process of making the necessary changes needed to living a healthier lifestyle with the goal of improving your overall health. My name is Dr. G, and by now I hope you have already hit the like and subscribe button. It helps the channel tremendously, so please do so before you go. If I told you there was a therapy that could reduce the incidence of type 2 diabetes by up to 58% and cut major cardiovascular events by around 30%, or add years of life free of cancer, or reduce the symptoms of COPD or heart failure and dementia, and also improve quality of life across the board, you'd probably ask three questions. Number one, what's the drug? Number two, why isn't every patient already on it? And number three, how much does it cost? And the answers are this. It's pretty simple. Number one, it's not a drug. Number two, because patients, doctors, and insurance payers haven't really committed to using it. And number three, it costs less than 99% of the drugs we already use for these diseases and with much better outcomes. So what is it? It's comprehensive lifestyle medicine and behavioral changes. Not the one-liners at the end of a visit kind. It's the kind that's delivered with the same rigor, structure, and accountability we expect from pharmacotherapy that we use every day and procedures we currently push on patients. And definitely not the overall suboptimal metrics many doctors and insurance payers stress about every quarter. Seriously, from time to time, I do get insurance companies visit my office or join on calls, and they often ask me what I need to help my patients or their customers. And honestly, I'm not always sure where to start. Well, now I absolutely do. From now on, this video is going to be my guide to the response that I give them when I get that question. So let's get into this important topic. With respect to lifestyle medicine, landmark trials and guidelines are remarkably consistent. Intensive lifestyle interventions centered on nutrition, physical activity, weight management, and behavioral change prevent, treat, and when done systematically, can reverse our most common and problematic chronic diseases. I'm talking stuff like type 2 diabetes, cardiovascular disease, hypertension, high cholesterol, heart failure, cancer, asthma, COPD, and dementia. And when we do them comprehensively, something we also call a multi-component intervention, not a diet only or not walk more only, or we're talking integrated programs with coaching and follow-up. Lifestyle changes consistently beat single component approaches. So clearly, the problem is not evidence. We have plenty and it's been proven over and over. The problem is translation and implementation of the evidence. We have random controlled trials and meta-analyses. What we don't have yet is a standardized, methodical, effective implementation at the point of care. And that's what I want to talk through today, so hopefully we can all make the changes we need to make it happen. So in this video, we will talk about, number one, what the evidence actually says about lifestyle medicine. Number two, why comprehensive programs outperform diet or exercise only. Number three, which behavioral and digital components make the best difference in real-world outcomes. And number four, how I'm talking about, doctors and insurance companies, the people who take care of the patients out there, can integrate this into our practices without burning ourselves or our patients out. Part one, lifestyle as a disease-modifying therapy. Let's discuss some of the strong data as it relates to real-life examples of some of the most common chronic and debilitating diseases we all deal with here in the real world and how lifestyle can influence them. Let's start with type 2 diabetes, because the story there is it's crazy how clear the evidence is. The Finnish Diabetes Prevention Study and the King Study are landmark randomized controlled trials all doctors hear about, which all converge on the same message demonstrating that intensive lifestyle interventions centered on individualized reduced calorie meal plans and significant weight loss and increased physical activity are highly effective in preventing or delaying type 2 diabetes and improving cardiometabolic risk factors such as blood pressure and lipids and inflammation. Typical goals of intensive lifestyle intervention include targeting more than 7% weight loss, typically as high as 15 to 20% in some studies, and greater than 150 minutes or equal to 150 minutes a week of physical activity, resulting in reduced progression of diabetes from 30 to 58% over 3 to 6 years. And these are not temporary benefits. Follow-up from the King studies show sustained impact on diabetes incidence and cardiovascular disease mortality for up to 30 years. In other words, a few years of structured lifestyle intervention can change the trajectory of decades of cardiometabolic risk over 3 or more decades even. And for people who already have diabetes, the Look Ahead trial shows that intensive lifestyle changes leads to significant and sustained weight loss, improved glycemic control, and reduced need for medications. And all this data came before a newer, smaller study published this year looking at the effect of hypoglycemic agents with weight loss effects, plus a high protein diet and moderate exercise, or on diabetes remission in adults with obesity and type 2 diabetes. This was another randomized controlled trial I've done a video on all by itself because the results were so good, and you can check it out. Check it out right here. We'll put it right here for you to look at. I will say this, 87% of the participants treated with weight-lowering diabetes medications and an intense lifestyle change program, they all sent diabetes to remission and no longer required medications to control their diabetes after a year. And when it comes to diabetes management, the data is clear, and we definitely aren't using all of our available tools. We have the power to not just slow the train in many patients, we can actually change the tracks. On the cardiovascular side, a study called the PREDIMED tells a similar story. There, researchers proved a Mediterranean diet enriched with olive oil or nuts reduced major cardiovascular events by about 30% in high-risk individuals. Systematic reviews and guidelines back all of this information up. Dietary patterns like Mediterranean and DASH diets, coupled with regular physical activity and smoking cessation, lower blood pressure, they improve lipid profiles, they reduce inflammation overall, and lower cardiovascular disease events and mortality. The American Heart Association now explicitly frames these patterns and behaviors as core tools to achieve life's essential 8 and reduce cardiovascular mortality, not as optional wellness extras. Let's talk about some other very common preventable chronic diseases influenced by lifestyle behavior. We're talking hypertension, lipids, heart failure, cancer, asthma, COPD, and dementia. Now, we see the same pattern across conditions. Hypertension and lipids, random controlled trials show that DASH and Mediterranean and plant-forward diets, plus physical activity and weight loss, significantly reduce blood pressure and improve LDL and triglycerides. Heart failure prevention. We have longitudinal cohorts and expert consensus statements highlighting optimal diet and activity from early life as foundational to prevent heart failure and preserve cardiometabolic health. Cancer, asthma, COPD, and dementia, we have data there too. Large cohort studies showing that a healthy lifestyle profile, normal BMI, physical activity, not smoking, moderate or no alcohol intake, adds years lived free of cancer and asthma, COPD, heart failure, and dementia. The effects are additive. The more healthy behaviors, the more disease-free years. Let's talk about dementia specifically, an important topic for most of us as we age. And lifestyle medicine interventions have a meaningful impact on the prevention and management of dementia by targeting modifiable risk factors and supporting overall cognitive health. But the earlier you start, the better. Exercise is the most consistently effective single lifestyle intervention, improving various cognitive functions in people with mild cognitive impairment, also called MCI, and early dementia, with stronger effects when initiated at the mild stage or before. Comprehensive lifestyle medicine approaches that integrate exercise and healthy diet and cognitive and social engagement and vascular risk management are the most effective strategy to prevent or delay dementia onset and progression. And early intervention, especially at the MCI stage, maximizes the cognitive benefits. So while individual components like exercise have strong evidence, multi-component programs address the multifactorial nature of dementia and yield the most robust outcomes. Lifestyle interventions, combining diet, physical activity, you have cognitive training, social engagement, and vascular risk management have demonstrated cognitive benefits in at-risk older adults, as shown in a Finnish trial called the FINGER trial, and supported by systematic reviews of the literature. So the consistent message is this: lifestyle medicine is a first-line disease-modifying therapy, not an afterthought. Hey, let's take a quick pause here, because if this information is speaking directly to you and you're thinking to yourself, okay, I'm ready, but I need a real system I can start myself today, I've got something for you. It's my book, Reclaim Your Health. It's a 90-plus page doctor-led lifestyle workbook that gives you a metabolic reboot plan, creating your own process of how to set your health goal and map out how to get there, practical exercise templates along the way. You have stress and sleep protocols built in, identity-based habits, and a clear step-by-step framework you can follow, written by me. And it's the same structure I use when coaching my private pay clients here in Hollywood. If you want something simple, realistic, and actually doable, hit the link below and grab your copy today. Now back to the video. Now, let's talk about why comprehensive beats diet only. The next question is important. Does it matter how we package lifestyle medicine? The answer is unequivocally yes. Let's start with type 2 diabetes. In the diabetes prevention program and related trials, all lifestyle arms did better than just usual care. But when you look under the hood, three things became clear. Number one, programs that target both weight loss and physical activity have the largest impact. In the diabetes prevention program, participants who met both goals had the greatest risk reduction. But even those who only met the activity goal reduced diabetes incidence by 44%. That's actually pretty good. In the King study, diet only, exercise only, and combined interventions all reduced diabetes risk versus control. But combined interventions had the strongest long-term effect on diabetes and cardiovascular mortality. Number three, the data shows that serious results come from serious structure. Commitment to frequent visits with coaches, setting clearly defined goals, creating modes of self-monitoring, and building in accountability produce infinitely better outcomes versus vague advice to just eat better and move more. Cardiovascular disease, obesity, hypertension, and lipids are three more chronic conditions causing big issues all over the country. And the systematic reviews comparing dietary programs show that Mediterranean, DASH, and similar diets and similar patterns reduce events and risk factors more consistently when they're delivered as part of a multi-component program. That means diet, activity, plus behavioral support. Across obesity, hypertension, and dyslipidemia, the strongest and most sustained improvements come from the intensive multimodal interventions that include your nutritional prescription, structured physical activity, and behavioral strategies like goal setting, systematic self-observation and self-correction, and problem solving. And also regular follow-ups and feedback on the progress. Diet only and exercise only arms do improve numbers, but they typically produce smaller, less durable changes than combined programs that are more complete. And even in asthma and COPD, combined lifestyle interventions like diet, activity, and smoking cessation yield better improvement in symptoms, quality of life, exercise capacity, and BMI than any single component alone. And in cancer and dementia prevention, it's the profile that matters as well. The weight, activity, tobacco, alcohol, and diet in each patient together are very important. Healthy behaviors are additive. 1 + 1 here does equal 3. So if we reduce all of this to a single precision sentence, it's this. Multi-component, high-contact lifestyle programs consistently outperform diet-only or exercise-only approaches across chronic diseases in both risk factor control and hard outcomes. So let's talk about what actually makes these programs work, the behavior or the digital part of it. And now to the practical system level question. What separates a lifestyle program that changes someone's life from one more handout in an EMR acting as a Hail Mary pass and hopefully it's going to work out? So what are the components of a successful behavioral change program? The behavior change literature is clear and beautifully aligned with the diabetic prevention program, the cardiac rehab, and the American Heart Association or the American Diabetic Association guidelines. Effective programs usually share these three elements. Number one, high contact and duration, at least 12 contacts over 6 to 18 months. Ongoing, often monthly support to sustain the changes. Number two, evidence-based counseling strategies, motivational interviewing, collaborative goal setting and action planning, problem solving around barriers, self-monitoring and correction for weight and food, steps, blood pressure, glucose, specific timely feedback are all necessary. Number three, structure and specificity, Clear prescriptions or instructions from providers like what to eat, how much, when, what activity, how often, at what intensity, measurable targets, not vague aspirations. Number 4, social and environmental support. Group visits or cohorts, peer support and vicarious learning, involving family or caregivers when appropriate. Number 5, personalize or tailoring the program to culture, language, health literacy, readiness for change, and life circumstances. When these elements are present, we see better adherence, more weight loss, better glycemic control, and more durable cardiovascular risk reduction across the board. So the difference between digital or in person. A lot of people ask, does it have to be in person? The answer, based on current evidence, is no. If the digital program is structured, interactive, and behaviorally sound, outcomes are comparable. Telehealth, app-based coaching, SMS programs by text, and web-based platforms have all shown similar improvements in A1C, blood pressure, and weight compared to clinic-based programs, especially for patients who are already somewhat tech literate and motivated. Particular benefit for people with mobility limitations, dual residence, or transportation barriers. Now, where digital struggles more is in older adults with low digital literacy, lower socioeconomic status without reliable internet or devices, people with high complexity and very low support. For these groups, in-person or hybrid models often work better and should be employed when it is available. So the real move or question is not digital versus in-person, it's matching the modality to the patient's profile and equity context. Finally, none of this stuff, none of it works if it depends on one heroic clinician doing a little counseling in a 15-minute visit every other month. This is where primary care physicians need help, especially from payers. The programs that move the needle the most use multidisciplinary teams that involve dietitians and psychologists and behavioral specialists and health coaches, and other doctors and community health workers and pharmacists and nurses. These programs need to be funded somehow to be as successful as possible. And if possible, all these team members should be integrated into primary care, cardiology, endocrinology, oncology, and pulmonary clinics, as well as community and digital platforms. It's obvious these multidisciplinary programs need to be funded somehow to be as successful as possible, and given the possible outcomes, there's no doubt it's worth the trouble. My personal role as a physician is to prescribe and champion the program, not to personally deliver every single component because that's just not possible. It's not possible to deliver fully on all the needs of the program. But my involvement in the program still is absolutely needed and absolutely essential. So where does all of this leave us? I mean, we have landmark random controlled trials showing 30 to 58 reductions in diabetes incidence and meaningful reductions in cardiovascular disease events with structural lifestyle interventions, even remission at 87% in some cases. We have cohort data showing more years lived free of cancer, COPD, heart failure, and dementia when multiple healthy behaviors are in place. We have meta-analyses and scientific statements from diabetes, endocrine, and cardiology societies telling us that comprehensive lifestyle programs are first line or fundamental for chronic disease prevention and management. We know that multi-component, high contact, behaviorally sound programs outperform single component ones. We also know that the digital and hybrid models can extend reach and equity when thoughtfully designed. And we know that a fully functioning lifestyle program requires an investment of time and money, but the outcomes and benefits cannot be any clearer. The question is no longer, does lifestyle medicine work? The question is, will we finally practice in a way that reflects the evidence? So here are 3 concrete shifts that we can make and commit to starting even now before the whole programs are all fully built out on all networks. 1, prescribe lifestyle programs with the same clarity and urgency as medications. Do the parts you have for now until we get the big piece and give it a program name, a contact frequency, and targets. Clear indications of diabetes prevention, secondary prevention of cardiovascular disease, obesity, heart failure prevention, etc. Number 2, build or partner with at least one comprehensive multi-component lifestyle program if you have one in your area, and engage various insurance payers to support a program for their members if they don't already have one. in-person, digital, or hybrid, but with nutrition, activity, behavior support, and follow-up is essential. And number 3, match patients to the right modality. Tech comfortable and busy, digital or hybrid. High complexity, low digital literacy, or significant social barriers, more in person, more touch. If we do just those 3 things consistently, we will reduce diabetes and cardiovascular disease incidence meaningfully. We'll improve quality of life for those already living with chronic diseases, and move from simply managing decline to creating more years of healthy, functional life. That, to me, is the real promise of lifestyle medicine. Not just adding years to life, but adding disease-free, purpose-filled, high-quality years to our patients' life stories. So that's it for this video. Stay healthy, stay informed, and I will see you soon.